Well, hello everybody. We're going to talk about how physicians are paid. The basics are fairly simple. Revenue minus expenses equals pay. It would be nice if it was actually that simple. Physicians have multiple potential sources of revenue, such as ancillary services, external support, patient billing, revenue sharing, and also incentives and bonuses. However, it is primarily through patient billing that physicians derive revenue. This is mostly a quantity-based factor in the generation of revenue. The more patients you see, the more revenue you generate. The more procedures you do, the more revenue you generate. Changing, and is now also going to have a quality component. The significance of that quality component is expected to grow substantially over time as healthcare payment systems evolve. So the relationship of pay to revenue is revenue primarily through billing for patient services minus expenses equals pay. These expenses are things such as malpractice, insurance, office space, personnel, debt, taxes, utilities, advertisements for new patients, the electronic health record, and other expenses. For some practices, such as a hospitalist practice, these expenses consume about 40% of the revenue brought in to the practice. For clinic-based internal medicine, these expenses grow quite substantially to about 61% of the revenue generated by the practice. So revenue minus expenses, which are generally more than half of your revenue, equals the amount of money that's left over for physician pay. Is it really that simple? Again, it'd be nice if it is, but it often is not that case. Most practices use a compensation model to approximate this relationship. So you usually have a base salary plus some sort of production benefit, which, when added together, equals your overall income. Over 75% of practices use a model like this. So when you look at the healthcare challenges of cost, quality, and value, how might this also factor into how physicians are paid? Well, many practices now include a quality bonus, often looking at specific quality measures that are relevant to the overall quality goals of that practice. About 40% of practices now include a specific quality bonus. So how do you measure physician productivity? Well, 57% of practices measure physician productivity with RVUs, or relative value units. For example, a hospital admission, Level 3 CPT code 99223 is worth 3.86 relative value units. A Level 1 hospital admission, CPT code 99221 is worth 1.92 relative value units. So it's important that you understand a few facts about your specialties. What is the average workload, such as the number of patients or number of cases per year, RVUs, and collections? Unfortunately, you won't find answers about this in PubMed or UpToDate. You need to look elsewhere. Physician productivity data is published by the Medical Group Management Association, also known as the MGMA. It is an annual survey of over 60,000 physicians, and this is what's used by many practices to develop compensation models. The data includes RVUs, charges, collections, the number of patient encounters, compensation, bonuses, and other things like the number of vacation days per year. It's also highly localizable, where you can look at physician compensation by different geographic areas. You can compare rural to urban compensation, academic to non-academic compensation, and other factors. So how detailed is this data? Well, it's quite detailed. If you look at the sample table, which just looks at physician charges, you can see that for allergy and immunology, they surveyed 25 physicians and 8 practices with a mean gross charges of $1,335,000 per physician. They also have percentile ranges and the median as well. You can contrast this to cardiology, particularly electrophysiology, with a mean gross charges of $2 million per year, with a 90th percentile of $3,500,000 per year. If you look at annual RVUs by specialty, family medicine has a mean RVU generation of almost 5,000 RVUs. The median is a bit lower, 3,800. And if you compare that to internal medicine, it's very comparable for a clinic-based practice. When you go to an inpatient-only practice, such as an internal medicine hospitalist, the number of mean RVUs is a bit lower at 4,500 per year, with a median of 3,200. The distribution is clearly skewed to higher productivity, but that's because there are often outliers that produce very heavily. The number of annual patient encounters also differs substantially by specialty. Family medicine, a mean of 4,300 encounters compared to a hospitalist at 2,400 encounters per year. If you look at the medians, the numbers are even lower. An internal medicine hospitalist seeing about 1,600 patients, in contrast to a family medicine physician who might see about 3,000 per year. When you look at compensation by specialty, mean compensation for family medicine is $226,000, internal medicine $225,000, but when you look at the hospitalists, for mean compensation, it's a bit higher at $253,000, and this likely reflects differences in practice expenses of a outpatient practice versus an inpatient-only practice, and a high demand for physicians who are willing to work nights and weekends in a hospital environment. So why is this important? Well, it's because you need to understand the compensation model and how it applies to you. What is a reasonable base salary? Are the productivity expectations reasonable? And will your pay be comparable to that of other physicians of the same specialty in the same general area of the country? How will quality bonuses influence this? You also need to think about how your productivity reflects quality and value to the healthcare system, and how that also impacts the costs of healthcare delivery in your healthcare system.